Hey, cowboy. I've got something important to talk to you about. Have you ever heard of your prostate? It's a small, heart-shaped organ located behind the bladder and in front of the rectum in men.
That's not the way I heard it.
It surrounds part of the urethra, the tube that carries urine from the bladder.
Any more good news?
The prostate produces secretions that provide nutrients to sperm.
Wow.
Back in the old days, the doctor used to make house calls.
Hello, Phil.
Hello, Lefty.
It's been a long time.
Yeah, it has.
World treating you all right?
Not complaining.
Meet my new partner, Fingers Blake.
Some men are especially nervous about getting a digital rectal exam.
When will that be? Today, mister.
It isn't such a big deal, and it may save your life.
You got any objections?
Nowadays, there's also a blood test called a PSA that men should have.
Why?
Because the test telegraphs potential prostate problems.
Unbelievable. Just think of it, Jess.
I am thinking of it, Frank. I'll be thinking of it for a long time. This'll be for Ma. Poor little Archie.
Remember, your prostate is an important organ in your body. Treat it as well as you treat your horse.
And what kind of help do you want from us?
If you're 50 years or older, visit your doctor and get a digital exam and a PSA test. Now do me a favor. Go out and tell the other cowpokes about the prostate. Knowledge is power. Growing old is mandatory. Growing wise is optional. Growing old is invariably fatal. Prostate cancer is only sometimes so. Every 3 minutes, a man is diagnosed with prostate cancer. It is the most common cancer in men and the second deadliest after lung cancer. Some think that it is an old man's disease and it won't kill you. While more men will die with prostate cancer than from it, every 18 minutes a man dies from prostate cancer. Dr. Anthony D'Amico is the Chief of Genitourinary Radiation Oncology at the Brigham and Women's Hospital and Dana-Farber Cancer Institute in Boston. Dr. D'Amico is also an Associate Professor of Radiation Oncology at Harvard Medical School. He has gained international notoriety for his work in detection, staging, and treatment of prostate cancer with over 100 peer-reviewed publications and has co-edited 4 textbooks in urologic oncology. Men who are concerned about prostate cancer need to become advocates for their own health care. Dr. D'Amico offers this advice.
The most important thing is to know your own status. If you have a dad, a brother, an uncle who has prostate cancer, you're at higher risk. And so screening with PSA is something I would recommend. In fact, because the change in PSA from year to year is actually more important than the level itself, I recommend for people who have a family history to get a baseline at the age of 35 and then start at 40. And for those people who have physicians who are still questioning the value of PSA, recognize that every September at almost every major medical center in this country is Prostate Cancer Awareness Month, and free screenings are offered by the American Cancer Society. And so you just have to look up the major hospital in your area in the month of September and see where the screenings are being done. They'll do a rectal exam, they'll draw a PSA, and you'll have that information, and you should keep a file. You won't remember next year what your PSA was last year. You need to keep a file. And if you see your PSA rising by more than a point in a year, that's a cancer that's still curable and probably significant. If it rises by more than 2 points in a year, whether it goes from 0.5 to 2.6 or from 3.5 to 6, you really need to have that acted on quickly, because it may already be a situation where the cancer is more aggressive than what just local treatments can handle. Bottom line is, you need to know your status. Get your PSA annually. If you can't get it through your local doc, go to a screening clinic because they're provided free of charge. Keep a copy of the report in a file so you know where things are at with your particular case. When you visit your primary care doctor, take a copy of those PSAs with you and sit down with him or her and look at them together.
Prostate cancer is not fussy about which men it strikes. There are risk factors that men should understand.
The major risk factor for prostate cancer is a man's age. Prostate cancer really is a disease of the aging process. Most men who have the disease diagnosed usually are in the early 60s, and this can extend into later 70s, and there is a growing number of people who are diagnosed in their late 40s and 50s. There are certain ethnicities that are at particularly high risk for prostate cancer. The one known most is African American men, as well as Haitian men, whereas Asians have a lower risk than the typical Caucasian male. Having said that, really nobody is without risk of prostate cancer as they age. The lifetime incidence for a man in the United States is 1 in 6. And prostate cancer takes the lives of about 29,000 men per year in this country, although that number is decreasing, and there's a number of possible reasons why, which we can discuss.
Over the past 20 years, the number of men diagnosed with the disease has risen dramatically.
In 1989, the use of prostate-specific antigen testing became available in the United States. PSA, or prostate-specific antigen, is a serum or blood test that men can get annually from their primary care physician. By using the blood test, you can pick the disease up at a much earlier phase in its development, a phase where it's typically more curable and certainly more treatable.
The PSA test has become one of the primary measures of prostate health. Yet there is some question among medical professionals about its usefulness.
The incidence of prostate cancer used to be on the order of 40 or 50,000 cases per year, but in the last decade with PSA it's increased to over 200,000 cases a year. The question that has risen as a result of this marked incidence is, are we saving lives by finding the prostate cancer earlier using PSA? And the data so far suggests, although doesn't prove, yes. And are we diagnosing men with prostate cancer who would have never needed to be diagnosed simply because the disease now, the blood test is so sensitive, it picks up disease that would never become clinically significant. This is an argument, but most people believe today that most cancers that you can detect with PSA and find on biopsy are significant, and that PSA is likely decreasing, responsible in part for the decreased death rate from prostate cancer in this country. So just with respect to just using the PSA test and having a cutoff of 4 or 2 or 2.5, this is also controversial. Not all primary care doctors recommend PSA testing for men after the age of 45 if they have a family history, or if they're African American or Haitian, or after the age of 50 if they're just a common American male without any other risk factors. And the reason why is because the large randomized screening studies, which will prove with impunity whether survival is increased or mortality from prostate cancer is decreased, are finished but not reported yet. It's estimated that about 75% of men in this country have had at least one PSA, but fewer than half of the men in this country actually have a PSA test each year. Now, going on to velocity, this is a relatively new idea which was introduced last year in the New England Journal of Medicine as of potential importance in not only the diagnosis of the disease, but in determining whether the disease actually is one that you can cure with treatments directed at the prostate, or whether more than treatment directed at the prostate is needed for cure. And specifically, the bottom line was that it's not necessarily just the PSA level itself that matters, but its history. What was the level last year? What is it this year? Very much akin to the way we look at mammograms. We don't look at them in isolation. We compare them to the test from the year before to look for changes that raise clinical suspicion. The main line from that study was that if a PSA rises by more than 2 points in a single year, that the cancer is not only likely to be present, but likely to be present beyond the prostate and require treatments more than surgery or radiation, perhaps a combination, or perhaps the addition of systemic treatments such as hormonal therapy.
Prostate cancer may not cause symptoms for many years. When symptoms do occur, they may take different forms.
It is the rare person who presents with prostate cancer symptoms. It's the common person who comes in with just a change in his PSA or an elevation in his PSA that brings the cancer to medical attention. Benign prostatic hypertrophy, which is a very common disease in men, can produce symptoms of more frequent urination, difficulty urinating, difficulty starting and stopping the stream. But these are not symptoms of early prostate cancer. And PSA finds cancers well before they produce symptoms like this. So it's the rare person who comes in with symptoms from prostate cancer.
When a man is diagnosed with prostate cancer, a number of treatment alternatives are available to him.
The standard options for local treatment include a radical prostatectomy, which now can be performed in a number of ways, either open surgery, laparoscopic surgery, or surgery done with the assistance of a robot called robotic prostatectomy. Or there is seed therapy, which can be done in a number of ways as well, with ultrasound guidance, or in some select centers with MRI, magnetic resonance imaging guidance. And then there's external beam radiation, which today is all done with a 3D conformal or toxicity sparing approach. And this can be done with IMRT, which is one form of external beam radiation, protons, or photons, all of which are equivalent. For men whose prostate cancer is beyond the prostate, and the way you tell this is based on the PSA level, the Gleason score, which is what the cancer looks like under the microscope, and the clinical exam findings on rectal exam, there are combination therapies that are recommended. Either radiation and hormonal therapy, or surgery followed by radiation and hormonal therapy.
Every man's condition is different. Every man's body is unique, like fingerprints, so the treatment must be tailored to the individual.
The people who are the optimal candidates for treatment directed only at the prostate, surgery, seed therapy, or external beam, are people whose PSA levels are under 10, whose PSA has not risen by more than 2 points the year before treatment, whose Gleason score, what the cancer looks like under the microscope, is 7 or less, and whose clinical exam reveals no more than a small area that can be felt of prostate cancer on one side of the gland, not both. And finally, on the biopsy, in addition to the 7 or less, there are no hints of more aggressive disease. So if you have all the favorable characteristics, a local therapy alone is usually more than sufficient. If you have anything more aggressive, a Gleason 8, 9, or 10, a PSA over 10, a PSA that went up by more than 2 units the year before treatment, cancer on exam that's felt to be beyond the prostate, men who have these high-risk factors are at much higher risk for recurrence after local therapies alone, and so the physician community has moved towards combining treatments in those men.
Each treatment has side effects.
All of the treatments share one side effect in common, and that's the impact, negative so, on erectile function. While it is true that men of younger age and of good baseline function are more likely to keep it after any of the treatments, it is also true that men of any age can also become completely unable to have an erection after these treatments. With surgery, it happens immediately. With radiation, it's deferred. It can happen a year or 2 down the road. There are agents to correct this, although not completely in all cases. Oral agents like Viagra, Levitra, Cialis can be used. When they fail, there's injection therapy, there's a pump, and then there are actually penile prostheses that can be implanted. The complications that differ are those of the urinary stream and the rectum. The surgical approach can affect the urinary stream, particularly a man's control. And it has also been shown that surgeons who have a higher volume, more experience, are less likely to get into this complication than those that do the operation less frequently. Specifically, somewhere between 1 in 50 to 1 in 17 men will end up with incomplete control of the urinary stream after the operation. The 1 in 50 number, or the 2% number, comes from the experienced surgeons, and the 1 in 17 number, or the 6% number, comes from the less experienced. That's the uncommon problem. The very common one is stress incontinence. This can be seen anywhere from 1 in 5 men, with the best and most experienced surgeons, to 6 in 10 men, with surgeons who don't perform the procedure as often. And this stress incontinence means that when a man exerts himself suddenly, like if he gets up quickly from a chair, or if he swings a bat or a golf club, that he can leak. Not to the point where he's, wet his pants completely, but where there can be 3 or 4 or 5 drops of urine over the course of a day or during rigorous exercise. This could become significant. With regard to radiation, there are rectal issues, particularly rectal bleeding, that can be seen. It depends on the technique of radiation employed and the dose that's delivered. And this is true whether it's seed therapy or whether it's external beam therapy. The other side of that, though, is it's manageable. It can be detected through a colonoscopy and then coagulated during that procedure. It may require more than one visit to stop the bleeding completely. The feared complications after radiation, though, are situations where not only is there rectal bleeding, but there's infection, abscess formation, or fistulas, holes that develop between the rectum and the prostate, or the prostate and the bladder. These are not just the result of standard radiation doses, but excessive radiation doses that you see rarely, but can happen when you combine different forms of radiation together, like seed therapy plus external beam. It's rare to see these things after seed therapy or radiation therapy alone, but when you combine them, they have been reported. And these are the things that lead to loss of the ability to move your bowels through the normal route, and you end up with a bag or a colostomy. While these are uncommon, they're something people should be aware of when they're taking treatments that combine forms of radiation.
Men often think that they need to face prostate cancer alone. They don't.
The whole dynamic of introducing the word cancer into anyone's existence, male or female, is devastating. And it's devastating because when you think of cancer, the first thing you think of is death, as opposed to potential for cure. And even if there is a potential for cure, the next thing you think about is side effects. And so it's either side effects to get to prolong life, or it's death. So the truth is that it has to start really in the consultation with the physician. There needs to be a team approach where the physician provides the information, the nursing support provides reassurance and answers for questions, and access to support groups, which exist in almost every major medical center. What you find in a support group is a group of people who are knowledgeable about the disease and their own particular situation, and they can share with you their life experience going through treatment, dealing with side effects, dealing with getting good news about remission or bad news about recurrence. All of these things are important, I think, in terms of people making the adjustment to deciding on a course of therapy, recognizing what the side effects will be, knowing how to deal with them, and knowing what their chances are that at the end of all this, they're going to be able to go on with their life as expected.
Researchers around the world are searching for a cure for prostate cancer. They are also trying to determine the causes of the disease.
The exact cause is unknown. We know it's common, whether it's related to something in the diet, in the exercise pattern, in the air that we breathe, is still under investigation. In terms of prevention, there are a number of studies that have looked at various vitamins, minerals, and agents that may be able to lower the incidence. These are not studies that are conclusive at this point, but studies that have given us a good picture of what may work. All of these things I'm about to mention are being studied rigorously at this point. One thing that we used to think worked, we now know does not, is vitamin E. And this is a good example. Vitamin E was suggested from a lung cancer study to reduce the risk of prostate cancer, but actually didn't do much for reducing the risk of lung cancer. And so the study eventually was done in prostate cancer, and recently in the Journal of the American Medical Association shown to not be the case. Vitamin E does not reduce the risk of prostate cancer, but in fact, it increases the risk of congestive heart failure in men who have diabetes or hardening of the arteries, vascular disease. And so vitamin E actually is not a good thing and is no longer recommended other than just to take, your multivitamin, not recommended to take any extra doses. Things that are still recommended are selenium, 200 micrograms per day, green tea, a couple of servings per week, 2 8-ounce servings, cooked tomatoes, so-called lycopene substance, and the cooked tomatoes really need to be cooked. Tomato juice, pasteurized, processed, will not work, and low fat and high fiber. So these are things that are currently thought to add benefit, but the studies are underway to prove or disprove that. There's one other thing too, which is a medicine called Proscar. Proscar was studied in a huge randomized study to see if it prevented prostate cancer. The thought was Proscar shuts off the conversion of the male hormone testosterone to its active form in the prostate. And we thought that if you shut off the stimulation of the active form of testosterone in the prostate, you might be able to shut off or decrease the incidence of prostate cancer, since it's a hormone or testosterone dependent cancer. That study was published also last year in the New England Journal of Medicine, and it was a double-edged sword. What it concluded was that you could decrease about 25% of all prostate cancer. That was the kind I spoke about, the low-risk kind, the kind that's confined to the prostate, the low Gleason score type. But to pay for that, you increased significantly the worst kinds of prostate cancers, the Gleason 7s or higher. And so while you reduce the low-risk cancers that you can cure, you increase the type that you can't always cure. And therefore, it did some good, but some harm as well, and therefore it's not recommended. And this is why it's so important for certain things of this sort to be studied in large populations before they are just attempted. I think it's extremely important that if people are taking things in addition to medicines that are prescribed, that they discuss that with their physician to be sure that they're up to date on what's good and what isn't.
Cancer patients sometimes look outside of the United States for treatments or drugs not available to them in this country.
In terms of medicines, no. There are no approved medicines for prostate cancer that are in Canada, Europe, etc., that are not in this country. It's because the medicines for prostate cancer are so far and few between that when something is found, it's shared very quickly. In fact, this past year, Taxotere, which is a chemotherapy, was approved for use around the world for the treatment of advanced metastatic prostate cancer, cancer that's in the bone. With respect to techniques, yes, there are technical approaches to the prostate cancer that are available in other countries that are not widely practiced here. They're available but not widely done because the perception is that the toxicity is quite high. For example, high-intensity focused ultrasound, the so-called HIFU, is practiced in France. And what they do is very much the same way you ablate a kidney stone or a gallstone, they ablate the prostate piece by piece. Now you can do this, but the price you pay is damage to the urethra, the tube through which you urinate, and damage to the rectum. And so it's not practiced in this country, although I will tell you there are studies, one of which we're leading, in which we're trying to see if one could reproduce the lumpectomy and radiation model we have in breast cancer, where you take out the lump and then you give low-dose radiation to the rest of the breast as an alternative to taking the whole breast off, mastectomy. What we're doing is we're looking at whether MRI, coupled with some other imaging modalities, can identify cancer inside the prostate, use HIFU, high-intensity focused ultrasound, to focus in on the lesion and ablate it, just the small area, and then use low-dose radiation for the microscopic disease that remains. This is an ongoing study which will be compared to radical prostatectomy. And so what I'm saying is that there are technologies in other countries that are used that are not being used here because of perceived toxicity, but certain components of those technologies may be useful in aiding the discovery of future minimally invasive treatments in this country.
Scientists are searching for a cure or at least ways to control prostate cancer. Significant advances continue to be made.
The biggest advance is in terms of advanced prostate cancer is Taxotere. I mean, this is the first chemotherapy to show a survival benefit in men with advanced disease. And that's a big statement because we've been looking for 30 years for a drug to do this. So it's now being studied in every other aspect of the disease. For example, we're running a study here looking at whether Taxotere, when added to radiation and hormonal therapy in men with advanced but localized still disease, will prolong survival. And it's being looked at for men who have a rising PSA after hormonal therapy has stopped working as well, but before they have disease in the bone. So for advanced disease, I think that's the big story. For localized disease, probably the biggest advance is in quality of life. Procedures that minimize toxicity while still achieving the same level of cure. And they are available across the board. In the area of surgery, the laparoscopic radical prostatectomy has gotten men out of the hospital a day earlier, less blood loss, and quicker return to work. The cancer control, as far as we can see, is no better and no worse. But they're back. It's like any other procedure that's done through a scope as opposed to opening up the patient. Recovery is quicker. In radiation, the newer forms of radiation therapy that are more focal, that have radiation delivery effect that puts the high dose where you want it and then quickly dampens so that the dose just around the area you want to give it to is very, very low, has markedly improved our ability to deliver high doses and still spare the rectum and the bladder. And then one other thing which I think is very interesting is we've known for years that the prostate gland moves. And it moves about 5 millimeters, and that does not sound like much to you, but when your radiation beam is as precise as a millimeter or two and you've got 5 millimeters of motion, you have to widen your beam to account for that motion, and you lose the ability of this knife-like effect of the sharpness of radiation. So what we've done here, and some others have followed, is we've developed a way to immobilize the prostate during radiation treatment using what's called an intrarectal balloon. A small balloon that's blown up pushes the prostate against the symphysis pubis, the pubic bone, and holds it in place. So we can not only deliver high doses, but we can fine-tune and sharpen it to the point where we can exclude rectum and bladder almost completely in the high-dose radiation area, because now we've got a target that doesn't move. We don't have to account for motion. So in the low-risk, localized setting, improvements in quality of life have come from technical advance. In the high-risk, improvements in prolongation of life have come from new chemotherapeutic agents.
Maurice Maeterlinck wrote, "It is sad, but all things in nature are sad when we look too closely at them. Before we judge nature, or before we complain, we should at least ask every question we can possibly ask." If you have questions, ask your doctor or visit one of these websites.